So today I will be talking about anorexia nervosa. So first we're going to start off with the history. So Sir William Gull established the term anorexia in 1873. So he discovered that it was in males and females, and it was more in the folklore and theology time period, we're in the 1870s, and it was more of a devotion to God. It was very religious, I guess, to starve yourself for which God you were following. Then we moved to the early 1900s. So parentectomy was used in the early 20th century, which is basically a treatment for anorexia in this time period where they would actually take you away from your parents because they thought that it would cure you or help you get better, which I can understand in a way. Sometimes the pressure from your parents can make things very difficult. So next we move to 1980, where eating disorders section was added to the DSM-3. So we aren't at the DSM-5 yet. So these professionals considered anorexia to be linked to possible sexual origins, and like they said before, that they were linked to religion because people would starve themselves for their god. Next, we move later into the 1980s, where college campuses, like their counselors, started opening up more and making it more aware that students could come talk to them about anything, and some celebrities even spoke out about it, such as Princess Diana. She would speak about her own eating disorders, and I think that's very powerful to hear it from someone who's famous, just because, it's different hearing it from them because you think that their life's so perfect. So next we're going to move on to binge eating disorder is recognized as its own disorder. So that happened in 2013, and it was recognized as its own disorder in the DSM-5, and for the first time people could get treatment and it would be covered by insurance. So this is a diagnostic criteria. So for A, we have restriction of energy intake relative to requirements, leading to a significantly low body weight in the context of age, sex, developmental trajectory, and physical health. So basically this just means is that their body looks very underdeveloped for their age. And I think we've all heard of, like, according to your height and your age, you should weigh a certain amount. So their body weight is extremely low. So for B, we have intense fear of gaining weight or becoming fat. Sometimes they call this fat phobia for anorexic people. And basically you maintain a very low weight. Or C, we have disturbance in the way in which one's body weight or shape has experienced. If you've seen pictures of people with anorexia, you can see their rib cages under, and their stomach is like under the rib. They look very malnourished. So next we're going to move to the types of anorexia. So the first type we have is the restricting type. So they don't engage in binge eating or purging. It's basically starvation. Some individuals do not binge eat but continue to purge after small meals. So they will have very small meals, if that, and they may purge after, but it's most likely they just don't eat, which is very unhealthy for you and can lead to many other, diseases, or not diseases, but mental and medical issues. So next we have the binge eating and purge type. So this is where they will eat, they'll eat a couple days worth of meals and then they will participate in self-induced vomiting. Or they misuse laxatives, so they'll take a lot to make it pass through their system really quickly, and they don't retain any of that nutrition or fat or anything, and they maintain their low body weight. The binge eating and purge type has a higher impulsivity rate, which means, they're more impulsive to do things. So for the prevalence, it's way more common in women than in men. And I think this is really, I find this really interesting because, you know, as women, we see models and we think, oh my God, I want to look like them. But in reality, all the models are photoshopped. And, you know, us females, we think, you know, we have to look like them, which we don't at all. So it is far less common in males than females. For every 10 males, for every 1 male, there's 10 women who have it. It's usually in early adolescent girls, and it's very rare before puberty. And in high income countries, so we'd say like the United States, you know, England, UK, like the first world countries, because, you know, we have the privilege of doing, that was not the right word to say. We don't have the privilege of doing it, but we are more privileged when in these other third world countries, you know, they're starving, but they don't have another choice. So for causes of the disorder, so you're higher at risk of developing anorexia if you know, have an anxiety disorder or you have obsessive traits. You have an increased risk if your first degree relative had the disorder already. So say, you know, you had a parent that had it, you're more at risk of getting it. I found this part really interesting that identical twins have a significantly higher chance of getting, you know, anorexia than fraternal twins. And then it's also different brain abnormalities that can cause the disorder. So next we move to environmental. I slightly touched upon this already, but if there's a stressful life event, you know, maybe if you feel insecure, someone calls you fat, and, you know, that can be really stressful for you if you have bad self-esteem, and that can lead to the disorder. It can also be cultural. I touched upon this, where religion, it'd be known to starve yourself, you know, to devote yourself to your God. Modeling can also be a cause of disorder. You know, a lot of models, they're supposed to look a certain way in the eyes of other people, and they think that they aren't considered beautiful if they aren't maintaining a certain weight. Same thing with athletes. You know, you have to be really fit, you know, in the eyes of others, where you aren't really considered an athlete. So next we have treatments. So hospitalization can be required if it is very, you know, if your case is very severe, you might need to be hospitalized to restore the body weight. Some never have to go to treatment or anything. They can recover fully after one single episode of maybe just purging. And healthcare workers have to really change the way that the patients think about food, because in their mind, the food is bad. But they have to kind of rewire their brain to think, if I eat what's right, you know, I eat good food, I don't, you know, I plan out my meals, I'm not starving myself. They have to rewire their brain to make them think, you know, I can eat and still maintain a healthy body weight. So for psychotherapeutic, we have family involvement outpatient treatment. So basically, I read a study on this, and it involves the whole family going to therapy together, and I'd say it's sort of like an intervention to the person who's struggling with the disorder, and they'll talk about, you know, how it makes them feel, and they'll stay at home with the family, and, you know, the parents are kind of the supervisors of the patient, or obviously their child, making sure that they're eating at the right times, you know, eating enough, and the siblings would be kind of a support for their sibling, and because they would get, and we can all get annoyed with our parents, I guess, if we're living with them. So this is kind of like them to go to their siblings, you know, if they need to get something off their chest. But there's also singular therapy where the patient with anorexia will go, you know, talk about, and this is kind of where they start to rewire the brain, you know, to make them understand that food is not bad. So for some diagnostic tests, so first we have hematology, and this is when Leukopenia is common, which is the loss of all cell types, and this can make you anemic, which is the blood. Then we have serum chemistry. So this dehydration may be reflected by elevated blood nitrogen levels. So self-induced vomiting could lead to metabolic alkalosis. Then we have endocrine. This is when females have low estrogen and males have low testosterone because they're not eating enough. Because usually women who do have anorexia, they don't menstruate because their estrogen is so low. When you don't have enough estrogen, you don't menstruate. So for electrocardiography, this is where they have arrhythmias, and this can help them, determine if the patient is anorexic or not. And for bone mass, they have very low bone mass because they're not getting enough nutrients to their cells, so they're very brittle bones. So for comorbidity, we have bipolar and depression and anxiety. They can come from, you're unhappy with yourself. That's what a lot of anorexic people feel. They feel that, their body isn't good enough, and that, sorry, my dog's in here. They think that they're fat even though they're very skinny, and this can cause depression, anxiety, bipolar disorder. This can also, OCD is more common in the restricting type of anorexia, so this is when they don't eat, and they rarely have purging episodes. But for the binge eating type, alcohol and substance abuse is very common to come after. I guess they want something to fill a void. It's very uncommon that restricting and binge eating can intertwine with each other, but it's not impossible. It's very uncommon. So for prognosis, if they have anxiety or obsessive traits throughout their childhood, this could be something that could lead them on to believe that they have anorexia, because, if you have an obsessive trait, you're going to be obsessed with not eating, looking a certain way. Like I said before, it can be historical or cultural. They can starve themselves for their God. And it's also genetics. I mean, if a family member has had it before, you're more likely to get it than you would have been before. And this is my reference slide.